Hello, everybody in Korea. I'm sorry I was unable to be there. We had a positive test result in my family before we traveled over. Therefore, because the PCR test, I thought it was a little risky for us to be there. So I do appreciate the opportunity to present. I really appreciate the scientific committee for WFSS and for inviting me to speak and wish I could be there in person to discuss this. I'm going to be discussing keeping the brain out of the bucket, the changing paradigm of epilepsy surgery, and the potential of neurorestoration through directed brain stimulation. My name is Jamie Van Gumpel. I'm a professor at the Mayo Clinic in Rochester, Minnesota, which I'm broadcasting from here today. I do have some disclosures relative to this talk. Of course, we have funded research with Medtronic, and some of these devices are utilized with this. We're a site for the Nautilus study, which we'll talk about NeuroPace. Also have stock and company ownership in NeuroOne and Cadence. The devices we're talking about are leading to a national trial, which will be initiated likely next year, and some educational grants as well that are relevant to this talk. Surgical epilepsy options for localized, eloquent onset epilepsy are limited and oftentimes unsuccessful. In the past, we learned that resection is an option, obviously, with possible seizure control. As you know, we can not control seizures with probable deficit. We've went through a period of time in which multiple subpile transections are an option, which and continue to still be available, but are falling out of favor, in which there's potential seizure reduction and possible deficit. And more recently, RNS, which there's a 50% reduction in seizures. Few of these patients are seizure-free, however, and they can oftentimes still have the event just shorter in circumstances, and they can suffer some of the same symptoms. So why do we care about using stimulation to control epilepsy? And how do we compare it to a lot of the talks here at this fine meeting, like movement disorders? Well, in movement disorders, the current state of affairs is a field stimulation, which is much, much better than ablation or destructive procedures. And the positives are it's non-destructive and reversible. And the downside is that it is expensive and there's device failures. Stimulation for movement disorders is by definition subclinical. So then why is it that the only device that we use for epilepsy currently or FDA approved is supraclinical? And I'll blame the cardiologist based on why these devices exist, like pacemakers. So published in 2011 is a landmark study, obviously in the Green Journal, which was safety and efficacy for NeuroPace, where 240 patients were enrolled, 191 implanted over 31 centers. Our centers happened to be one of them. 50% of the patients implanted had mesial temporal seizures, 73% bilateral, 18% left. And this provided class 1 evidence for reduction of seizures with these devices. And what was very impressive in this study, obviously, was that implantation itself led to a reduction in seizures. And once a month period of recording had been completed, they turned either device on or continued to record and not turn it on, and the patient was unaware of this. And in the patients that were stimulated, they had a progressive reduction in seizures, and those that were not returned back to baseline. What was cool is that if they turned it on, there was an improvement in seizures, obviously, and those that remained on had a progressive improvement over time. That's something that we've seen more and more over the years, is that the longer-term outcome studies with this is that at 8 years, at 10 years, there's a continued improvement with these types of devices. So the directed stimulation with RNS, the positives are that there's a greater than a 50% reduction with a 50% with 50% or more patients responding. The responders improved over time. SUDEP dropped by 50% compared to historical controls. The negatives, however, of course, are that seizure prediction is very complicated. Some of these patients still have seizures, but they're more limited to focal onset seizures. And the trial data was that those that stimulated most frequently responded best. And I think that's used in the programming nowadays, where a lot of people are continued or have their stimulation parameters set to very light detections. So what happens if you take the detection out of it? And I don't want to say make it idiot-proof, but make it more of a open loop stimulation like we have in movement disorders, and make it like movement disorders, rather than having a larger clinical dose of electricity, use something that is clearly under clinical capture of the motor or whatever eloquence in that area we see. And that's something that we've been proud to investigate quite frequently at the Mayo Clinic. And our landmark publication for this was Continuous Cortical Stimulation, published in JAMA Neurology 2016 by Dr. Lundstrom. And we'll take you through some of those patients and some of the more modern data associated with this. Our indexed patient was implanted by my mentor, Dr. Kendall Lee, which was a 16-year-old female, history of intrauterine right temporal parietal infarction, focal epilepsy since the age of 3. She developed a 2-year history of persistent EPC involving the left thumb and hand, which was painful. She underwent a grid implantation. They found that they could suppress the seizures. She went a permanent implantation, with complete suppression. And interestingly, the battery ran out quite quickly, but the seizures didn't come back. Therefore, they waited a period of time to replace the battery. The seizures then came back after a series of months. And then they replaced the battery and were able to get capture again. There was a couple more patients like this over time. So we then began to wonder, what can we do with a patient with reflex epilepsy? So here's a patient who's 16 years old, history of intractable focal reflex seizures involving the left lower extremity. Their common triggers included standing or walking, and the patient was wheelchair bound as a result through their adult life. They underwent a partial resection of a cortical dysplasia at another institution in the United States in the parietal lobule in 2010. That got rid of the spontaneous seizures. However, reflex seizures continued to occur. They then underwent an insertion of vagus nerve stimulator in 2014 without any help. They then presented to our institution for further investigation. This is the MRI of that patient. You can see a prior resection right up to the motor cortex in the right parietal region. This is a SysCom showing a very focal SPECT abnormality that was hyperperfusing. This is after we placed a grid into this gentleman to try to cover this area. And this is what it looked like. So this is this patient's video. Here he's laying in bed with the grid in place. And what we're doing is simply by putting one of these bed bicycles in, you can see here simply by just picking up his leg, he's going to begin to have a seizure here. Here we have him implanted and we're trying to improve things. So he's actually able to mobilize. This is my colleague, Dr. Stead here. And he's actually able to weight bear on it initially. However, with full weight bearing over a period of time, he has seizures then. We ultimately decided to implant him and with a device because we've had some success to hopefully continue to improve this situation. And what you'll see here in the post-op period, this is post-op day 2, we've actually been able to stimulate him enough with that device that he's able to walk around in the hospital, which was quite remarkable. This gentleman saw me, he doesn't speak English, by the way, saw me in the mall a couple weeks later when he was recovering, came up and hugged me and tried to thank me in his native language. It was quite a powerful case for me and showed me the power of this particular device and abilities. And this is that permanent implant for that gentleman. Here's another patient, a 19-year-old right-handed man, 5-year history of intractable focal dyscognitive seizures in which he'd experienced intense fear followed by clonic movements of the hand. He had a diffuse onset seizure onset zone, which was identified when one of my colleagues implanted him. But he also overlapped with speech and motor cortex areas. This implant was done by Dr. Meyer. Dr. Meyer called me, and we found that there was an area that we could remove, and we had an extensive implant of subcortical, mostly 3389s and 3387 electrodes in this particular gentleman, in which we'd hooked up to an Intellis battery or a pain battery. At follow-up, this patient did not experience any post-operative complication, was discharged home on post-operative day 4. He was had some seizures in the immediate period before we turned him on. Once he was turned on and stimulated, he continued to be seizure-free for 47 months after initiation of stimulation. This is a 26-year-old left-handed male, 11-year history of focal dyscognitive seizures, described as a feeling of cold sensations of the entire body. tunnel vision, adventitious movements in his upper and lower extremities, and loss of awareness. His neonatal history was significant for stroke in the right MCA territory. His MRI revealed a perinatal stroke in that region. He underwent an SEEG by my colleague, Dr. Marsh. There was initial implantation suggested anterior insular focus. The patient was unwilling to consider insular resection due to co-localization with speech. I should note this patient's left-handed, obviously. And he underwent explantation. When we looked at his data, we felt that there was a possibility that we'd be able to control his seizures with the permanent implants. Therefore, we implanted 3389 electrodes into the anterior insula, and an additional 3389 electrode was implanted into his ANT, and this was hooked up to a prime advanced battery. This is this patient's story. So in the subsequent 6 months, the patient had 2 typical seizures compared to the clusters of up to 60 seizures every 4 weeks prior. And now for the past 4 years, he has not had any seizures since that period of time.
So you're going to feel a little scratch side to side.
Chris White couldn't tell you how many times he's had electrodes placed on his head. His first EEG test was done a day after he was born.
And after a bunch of different tests, they found out I had a stroke.
For 15 years, he lived a normal life. But after getting a concussion, Chris started sensing something was wrong.
I would kind of black out while I was sitting down and have a lot of different memory troubles.
Scar tissue from his stroke as a baby was causing Chris to have as many as 5 seizures a day. As it progressively got worse, it became impossible for him to drive and difficult to hold a job. It even took a toll on relationships.
Kind of at the point where I didn't feel like I was able to even go anywhere in life.
He started meeting with a team of doctors at Mayo Clinic that came up with an option they thought could help. It involves implanting Chris with a device that delivers a low level of continuous electrical stimulation to the area of the brain where his seizures are coming from.
Things on top of the
With an option they thought could help, and is happy to report he hasn't had a seizure since October. But that's not all he has to celebrate. 2 weeks before surgery, Chris proposed to his girlfriend Tina. He hopes the team of doctors that came up with a solution for him can use his experience to help others who may feel hopeless, like Chris once did.
Coming from a place that was very, very dark into a whole brand new life, that's my hope for anybody.
So quite a powerful message with this individual, and it's nice to be able to impact patients. I know we do this in a lot of. So this is our study population currently. 30 patients have been implanted. Ages between 6 and 56. Seizure types range from focal impaired awareness to EPC, multiple different types of seizure types. And this is our current protocol. They're admitted to the EMU and they undergo invasive EEG monitoring. If they're found to be a poor surgical candidate, they're offered off-label BTS or biomarker targeted stimulation. And the patients are mapped and screened by studying the biomarker responses, which is mostly spike reduction and seizure reduction off medications. Then temporary monitoring electrodes are removed. If it's SEEG, we wait a period of time before implant. And if it's strips or grids, we proceed directly to implantation. The device is then implanted and stimulation is begun after approximately 2 weeks. This is a classic case.
Our patient is a 21-year-old right-handed woman with intractable focal epilepsy. Seizure onset occurred at 9 years of age. Primary seizure semiology is characterized by left head turn and hypermotor bicycling movements occurring 20 times monthly, often arising from sleep. Rarely, seizures can progress to generalized tonic-clonic seizure activity. MRI revealed a left superior frontal sulcation anomaly. PET was notable for subtle hypometabolism in the left frontal and cingulate region, and MEG demonstrated a cluster of dipoles in the left frontal head region. Video EEG monitoring recorded 6 left frontocentral onset seizures arising from sleep. Further monitoring was completed with stereo EEG, targeting the hypothesized seizure onset region. Seizure onset was recorded from the LE and LN and LM contacts in the primary motor and premotor SMA region. Frequent interictal epileptiform activity was recorded from LE and LN contacts. Here is a seizure seen arising from LE and LN contacts. SEEG cortical stimulation mapping was notable for eloquent cortex co-localizing with the seizure onset zone. Stimulation of LE, LN, and LM contacts resulted in right hand and face motor activation. Given co-localization of seizure onset zone and eloquent cortex, a trial of therapeutic stimulation was delivered through stereo EEG hardware. Here we show the device used to deliver stimulation through the SEEG contacts. From left to right, we see a clinician programmer, a clinical telemetry module, and the external neurostimulation. There was a suppression of interictal discharges. Note a reduction in interictal discharges between the 2 Hz stimulation artifact. Following discontinuation of stimulation on the left side of the EEG tracing, we can see a transient suppression of interictal ding that was phase locked to the 2 Hz stimulation when amplitudes were increased above 3 volts. Following SEEG explantation, a permanent device was placed. The permanent electrodes are seen in yellow, and they are co-registered to the SEEG implant with seizure onset zone electrodes marked in red. For the permanent implant, 1 lead targeted the anterior nucleus of the thalamus, while 3 leads targeted the cortical seizure onset region. The patient has had 5 clinical seizures over 11 months following device placement, a greater than 90% seizure reduction.
And this is what that case looks like. So this is how we do it. We put him in a Lexel frame. We co-register with a Medtronic arm. We then figure out an incision that will allow all the entries and keep the pericranium down. We hope this ultimately reduces the chance of keeping the electrode settling into the calvarium. We then use this device that we made custom to target, like we do with our SEEG. We drill our SEEG holes. We then add this piece on that allows us to deliver the electrodes through typical cannulas, and then we'll do our cross-table lateral to be able to secure it in the appropriate position. So you can see here putting down a cannula. And then we'll just measure from the back and measure at the back table what the distance to target is. We'll do what we normally do. So here your electrode's in and secured. We're just going to mark it. We then do our cross-table lateral. So we know that we have the depth set up, and then we secure the electrode. I oftentimes close the pericranium over these just to make it so that they're less obvious. Then when we're done, we'll tunnel the electrodes here, bring it down. I'm going to speed it up a touch. We'll tunnel down to the neck. Twice you have to do that to pass these down, obviously in the dual connectors, into pain batteries. And here we're using an Intellis pain battery. We've had 2 updated publications on this series in 2019. In Brain Communication, we reported 21 patients. Median percent reduction in seizures was a frequency of 100%, a responder rate 89%. The median follow-up of 27 months. Now, remember that we eliminate non-responders with the temporary implants, so we know we have a reasonable degree of suspicion that these patients will respond. 40% of these patients were free of disabling seizures for a 12-month period or longer, which is certainly different than the RNS population. And our most recent case series results are that of 30 patients implanted and receiving BTS therapy, 93% median seizure reduction, 78% responder rate. statistically significant improvement in seizure severity over time, a significant improvement in life satisfaction, and 44% of patients free of disabling seizures at 6 months or more, 61% with 3 month or more seizure-free periods. And these are just representing that seizure freedom data at 3 months pre-op, 3 months post-op to last follow-up. So we see a persistence of effect. Same thing with seizure severity. They report that their seizure severities are certainly reduced, and this is maintained by last follow-up, and also life satisfaction. This is leading to a national trial in which we're utilizing this in a younger population between the ages of 12 and mid-20s, which will be a multi-center prospective case series. Has 2 components: a mapping station that you heard about, which screens and looks for biomarkers that we use to predict if this is going to be successful, and also an implantable device, which will be released next year and investigated in this study. We also currently have a randomized trial going on within the Mayo Enterprise, looking at the BTS, or the biomarker targeted stimulation, currently with the device that will be available within this trial, looking at spike suppression and other markers, novel biomarkers, which will be helpful for predicting implant success. If you're interested in learning how to do this, we have a course that will be set up on October 13th and 14th in Rochester, Minnesota. Come join us. It's a beautiful time of year. We'd be happy to see you there, and we have a couple spots available, so please get online and sign up for this. I thank you for your time and attention, and I again apologize that I'm unable to be there. I know it's going to be a great location in Incheon. I wish I was there. Take care, and if you have any questions, please email me or call me.